So now I would like to introduce our speaker, Shane McGuire. And I did ask Shane with his name if he is Irish, and he in fact did say that he is fourth generation, but he's not. This is not a major holiday for him. So, so Shane McGuire is the CEO for Columbia County Health System. Shane is known as an innovative leader, recognized as a 2017 Community Star by the National Organization of State Offices of Rural Health. Shane is a CompTIA certified in project management and holds a Bachelor of Science degree in healthcare information management. Shane has been with the Columbia County Health System since 2010 and became CEO in 2015. Shane lives in Columbia County, Washington, with his daughter and Labrador Retriever named Samson. So Shane, take it away. It's all yours. Do you need this?
Are we good? Okay. Yeah, the Labrador Retriever, he's not the best boy. I tell him all the time, he's an okay boy. He's okay. He's getting better. I'm going to take questions during the presentation. It's my first time presenting here, and so I wasn't really sure how to tailor the slides, and I thought maybe you guys could help drive some of that by just asking questions as needed, okay? So she's going to monitor, and if you guys have something that strikes you, particularly on a slide, just stop and we'll get those questions answered. So when I tell my friends I work in rural healthcare, this is what they imagine. This is what I feel like I'm doing in rural healthcare most of the time. And so rural is a broad definition. 30 out of 39 counties in Washington State are classified as rural. And so, you have Walla Walla with 35,000 people, then you have Columbia County with 4,000 people. And so when we say rural, it really doesn't apply. And sometimes people want to say, well, maybe we should call it rural and frontier. And if you're in a smaller population county like Columbia County or Garfield County, it is a little more frontier. I was doing a presentation in DC and they were, like rural Maryland. Rural Maryland has like 75,000 people in it. And so I had to put it into context for them about what rural looks like. These photos were taken by Nick Page, a wonderful photographer from southeastern Washington. He allowed me to use these images to sort of give you guys perspective. But these are Columbia County images. So there's been this discussion about why do we need healthcare in rural at all? I mean, there's 40,000 people there. I mean, cost of having a hospital in a community of 4,000 people, it seems on its face like, well, maybe we shouldn't have it. Maybe if you live in rural, you have to accept the fact that you're taking that risk, that you're not going to have all the services you need, and if you need care, you're going to have to drive some distance to get it. But I want to say that there is reasons to support healthcare in rural. Washington State ranks 6th in the nation for wheat production. 60% of Washington's wheat comes from southeastern Washington, and 46% of the nation's soft white wheat, which is your crackers, your cakes, your muffins, come from Washington State. A lot of people don't realize that. Wind energy is a big deal in Washington State, is sort of converting our way to different energy, solar and wind. 56% of Washington's wind energy is produced in southeastern Washington. 26% of that is in Columbia County. So the average age of Columbia County, 28% over the age of 65. We have 4.2% over the age of 85. I think Garfield County is the only one that has a higher population of folks over 85 years of age. And the average age of Columbia County residents is 50.2 years compared to much lower state and national averages. So it sort of sets a precedent, older, potentially sicker. Because as you age through life, you will accumulate injury or you will accumulate disease. And so when we look at health outcomes and health factors, I don't know if any of you have looked up your own counties on county health rankings. It's interesting. We can have one car accident that kills somebody, and the premature deaths for Columbia County will be impacted greatly because of the population after they factored it. So they've stopped actually giving rankings. And they've started giving you these slider bars for the smaller communities. And so, we're ranked amongst the least healthy counties in Washington State. We have higher averages of diabetes, higher averages of obesity, greater percentage of people smoke in the county. And then when you look at the health factors, which really takes into consideration lifestyle choices, we're sort of in the lower tier of that as well. So payer mix is really relevant to this conversation because it has a lot of impact on how you choose to provide integrated care. It has a lot of impact on the types of providers you pick. So you can see from our payer mix, 59, almost 60% of our payer mix is Medicare. So we're a critical access hospital, and we have rural health clinics. And so, encounter rates are a big deal for us, but you have to play by their rules. You have to have the type of providers that qualify for encounter rate payment. And when I've been talking to some of my peers, it's not always the case. Like, they may have a more preferential payer mix, and they may have contracts that allow different types of professions to be reimbursable on their commercial contracts. So I was trying to figure out an analogy for our journey into integrated care. And it really is like, little kid with the floaters, right? Getting into the kid side of the pool, and you're like, yeah, I'm integrated. So how that started for us is we really started looking at what the need was. And so in 2017, we started doing population health screenings. I don't know if any of you are familiar with PHQ-9s or GAD-7s, but the PHQ-9 is a 9-question survey, and the GAD-7 is a 7-question survey. One determines depression, and the other one determines anxiety, okay? And so what we found after doing that on just the Medicare population, 30% of our population was clinically depressed. Another 14% had clinical anxiety. At the time, we weren't doing anything about it. We didn't even know about it until we started screening. And once we started screening, we were just like, what are we doing about this? For a child, 6-month wait to get into any kind of behavioral health. And it's a 70-mile round trip. So we looked beyond the Medicare population, took a look at the Medicaid population. Medicaid has 4 subtypes on here. Expansion was when we expanded Medicaid in Washington State, children and classic adults and disabled. So when we broke those out, the lowest need was in children, and it was still 45%. So 45% of the Medicaid children had some form of behavioral health need. 85% of the Medicaid disabled in our community have some type of behavioral health need. So I don't know if there's any ICD-10 people out there. You look up, like, hit by satellite first occurrence, right? So there's a code for everything. I did want to break out the codes that we see in our community, and I broke them out by numbers. And so the reason I wanted to tell you about Columbia County is so you can get context. The numbers aren't big. They're never going to be big. They can be a big percentage of your population, but it's not, tens of thousands of people. Unspecified anxiety disorder, 358 occurrences. General anxiety disorder, 144. That's significant for a small town. Major depressive order, the one that caught us all off guard was the PTSD. The amount of childhood trauma that has been carried in that community. And then when you start doing behavior health and you start unpacking some of that, it's unbelievable. And it's an unbelievable amount of work too. So we acknowledged our reality. We recognized that our ratio of behavioral health providers to population, it was 560 to 1. There weren't any there. I don't know how they get those numbers. Like, you look at a ratio in a community that has 0 psychiatrists or behavioral health, and they still come up with a ratio of 560 to 1, and I'm not sure where that came from. So we're going to make an impact on this. We're going to fix this. 60% of individuals suffering from behavioral health conditions receive no care at all. Of those that do, only 20% receive care from a behavioral health specialist, which is what was happening in our primary care. Like, our primary care docs would be meeting with somebody, and it would go from, well, I don't feel well, to, I've been really depressed lately. And then you got a PCP who was ready to deal with more of a physical symptom, slipping down that road towards behavioral health diagnosis. And it was challenging for them. So, we do these referrals. Again, people, when they are in some sort of behavioral health mindset where they think they need to get help, like telling them it's going to be 3 months from now, not beneficial. So most care being provided in primary care settings don't include integrated models of care. Most of the time, we are seeing some some programs like what the University of Washington has from the AIMS Center. I don't know if any of you are familiar with that, but it is essentially psychiatrists supporting PCPs in the primary care setting. And so you can bring a case, you can call them up, you can say, hey, here's a situation I'm having, and they'll get advice on what they should do. They may even get some medical advice from the psychiatrist on medications they can prescribe, okay? So psychiatrists, psychologists, licensed professional counselors, licensed independent clinical social workers, these are sort of all the mix. There's mental, there's MHPs, mental health providers. There's a lot of different classifications for behavioral health providers. Not every behavioral health provider is a billable provider, and not every behavioral health provider is a counselor. I actually, when we started this program, I came into my executive team and I said, hey, I found a psychiatrist. And they said, it's about time. I'm like, no, that's not what I meant. It took me a minute. But we did. We found a psychiatrist. He heard that we wanted to do an integrated model of care. He was very interested in what that would look like. And so we hired him. We were super excited about it, brought him in, and he started doing med management. He started looking at the whole person from a medical perspective. He would, prescribe medications. He was helping in our inpatient side. But we were billing for that med management, and we billed it the first time, but then when we billed it, we needed a follow-up. We didn't get paid for it. So we were in this fairly small community, and I'm like, when's he going to start talking to people? Well, he doesn't do that. He's not a counselor. That's not what he was going to do at all. And so we got about a year and a half down the road, and we found we really weren't integrated. We were more like co-located. And he wasn't very busy. This is a small population. Once he got his roster, and once he got his panel, and he kept them tuned up from a medication perspective, it wasn't working for us. We were learning along the way that what we really needed was counseling. We needed psychiatrists for the med management and some of that intervention and diagnosis, but what we really needed more than anything was counseling. And so we started looking at what kind of professions we could get reimbursed for. And like I said, being rural healthcare clinics, we basically started talking about, I'm going to skip some of these, I'm sorry. So Medicare and Medicaid recognize 3 professions in the RHC for encounter rate: psychiatrists, licensed clinical psychologists, and licensed independent clinical social workers. Okay, have any of you found these 2-horned unicorns? It takes 4,000 hours after they have their master's degree in order to get their LIC, their licensed independent, and there's not a lot of them. And where they are is they're in the urban centers, and it's really hard to get them recruited out into rural. We've been fortunate that we've had 3 providers that have come to work for us. We've built programs around them. The initial, when we talked to University of Washington about how this works, what they said is brief interventions. You're there for somebody who recently filled out a PHQ-9, maybe it's a seasonal thing, they're a little depressed. Get them engaged, get them in, get them tuned up, and then you discharge them from the program. When we started working in our community, what we found out is they don't discharge from the program. They have PTSD, they have childhood trauma, they have deep counseling needs. And so what we were finding is that we couldn't run the program the way it was designed. We were getting these people that were deeply entrenched and needed hours and hours and hours of counseling, which was restricting access. And so part of what we started doing was measuring time to first appointment, time to second appointment. And if our time to second appointment was stretching out too long, we knew we weren't meeting the community's needs. And so in any of these programs, when you start building them, you start learning very quickly what your community's needs are versus a perception of what you thought they needed. So payer mix, when you're hiring these professionals, raisins and cashews, right? Our payer mix is more raisins, and so we had to really stick to those recognized licensure levels, but there may be some people that have more cashews in their payer mix, and you can get different counselors and you can get paid for them, because commercial payers will negotiate those contracts. So these are the primary, most common billed services that we bill in our program. One thing that you'll notice pretty quickly here is 30-minute, 45-minute, and 60-minute slots. So if you're a provider in a primary care setting that's working 15 or 20-minute slots, you're not going to get the volume and the turn out of behavioral health that you do out of your PCPs. Most of the visits, the majority of our visits, are 60-minute visits. So telehealth services, we have been getting paid a higher rate for them through COVID. Our providers say sometimes that they stare at someone's neck through most of it. They're trying to do it on cell phones. They're trying to do it with low bandwidth in rural areas, and it hasn't been really effective for us. And the other thing is that our no-show rate went through the roof. As soon as we went to more telehealth, people didn't feel inclined to show up for the appointment. And so our providers were actually seeing less patients as a result of it. And then the one thing I really want to talk about is we see more of this being sold as this is what's going to fix rule, is these telehealth options. You know, integrated care sometimes takes us back into that room with our PCP, and that PCP is talking about diabetes or lack of diabetic control or their A1C, and then the conversation starts turning, and as soon as it starts turning in our clinic, what they do is they say, you know what, I'm going to go grab Wayne. Hang on one second. They walk down the hallway, they grab Wayne, who's the LICSW, bring him into the room, do an introduction, and do a warm handoff. It's a lot harder to do over a telehealth connection. And so that's the power of integration, is you can get to it right that second. You can bring them into that meeting at that moment. They don't have to do anything other than to say, I'm Wayne, I'd like to schedule an appointment. There's a face, it's a real person. And once we started doing those warm handoffs, our no-call, no-show rate dropped. They made a connection. And we intentionally hire people with different dynamics into the role. So Tasha, she was a substance use disorder, LICSW, it's where she's cut her teeth. But some folks, some women that came into our clinic didn't feel comfortable talking to a man about their problems. And so having the dynamic and having the ability to have different options for the patients worked well as well. So what we found in this process is that there's a lot of interplay between chronic disease and behavioral health. So we started a palliative care program. Are you guys familiar with palliative care? Okay. Progressive, chronic, debilitating disease. Okay. You're still doing symptom management. It's not hospice. But what we found is 60% of our palliative care patients had co-occurring behavioral health diagnosis, and 63% of our chronic care management patients also have overlying behavioral health or mental health issues. So CCM coding, for the people that are panelized in chronic care, some of our palliative care folks could be in chronic care as well, but not all of the palliative care folks were CCM patients. There are codes out there that allow you to get a monthly fee for the service, and it does take a multidisciplinary group. There's usually a behavioral health provider, there's an RN assigned to that patient, as well as the primary care provider. And there are some complexities with the charting and coding and the number of minutes that each of those disciplines spend with the patient. But if you code to that level, you can actually get a monthly fee for helping to manage these folks. So that kind of brought us to why, and then we formed it, and then we said, well, can we get paid for it? And we were getting paid for it using these traditional methodologies. It wasn't really covering its cost to operate. You can't push enough volume. Behavioral health is not a great fee-for-service thing. You're not going to rapid cycle people through it. So what we really did is we sort of got our toe into the water. We got our disciplines right. We built our program. We found some good partners with the University of Washington. But then we started noticing some interesting trends. The pool got really deep, okay? So we found out that within this population, their vulnerabilities were much higher than a lot of our other patients. Transportation was a factor. Early on in the program, we were having these patients would no-show frequently, and we talked to the providers, and they said, well, normally we just send them a letter and fire them. Okay, when you're in a population of 4,000 people, if you start firing people, you're not going to have anybody in your program after a while. But then instead of giving them the dirty letter about why aren't you making your appointments, we started having conversations with them, and transportation was huge. My friend couldn't give me a ride, my car didn't start. all of these hurdles. And so part of our behavioral health program became transportation. I mean, a car and a driver is going to improve mental health. And it does. It will, because it gets them to their appointment where they can actually get the care that they need. And so the rabbit hole kept on getting deeper with the overlaps between the chronic care management and the palliative care, the transportation, behavioral health integration. We integrated behavioral health into the school system as a result of some of the stuff that we were learning about the children in the community. And so, we had to recognize that a couple of things were happening. Some of these patients are frequent flyers in and out of the ER. Some of them had, chronic disease that kept them in and out of the hospital. But the more we wrapped these behavioral health services and transportation services around them, the less they came into the ER and into the inpatient volume. So we were sucking known revenue streams out by taking really good care of them, doing things we weren't getting paid for. And so we had to go out and start finding some sources for funding these programs. So one of the things that we've done is shared savings. So we're part of an ACO, and we know we need to drive down our costs per beneficiary in order to get shared savings back into the program. And so we actually started conscientiously recognizing the fact that behavioral health was contributing incredibly to those shared savings costs. And so we actually consider a large part of the shared savings that we've received, we sort of put it back into that program to keep funding it. So when you look at the palliative care patients, we dropped the ED visits by 52% and the hospital admissions by 45%. Those are significant numbers by just wrapping behavioral health and home-based services around them. So 90% of our palliative care panel are Medicare beneficiaries. So again, it lines very well with regards to the ACO. Demonstration projects. I don't know if any of you are familiar with the Accountable Communities of Health in Washington State. There's 9 ACHs defined. We're in our 5th year of that program. $50,000 a year of some of that money that we rent, we spend it directly on behavioral health and support of behavioral health. And we've recently heard from Greater Columbia that they're going to have a couple more years of funding. So it was a 5-year demonstration, but we're going to actually continue working with them. It won't be as much money, but it's still supporting integrated care models. So we also applied for a HRSA grant. We were one of 45 organizations nationally to receive the Rural Healthcare Services Outreach Program grant. It's about $1.2 million. In a large part, our response to this grant included the integrated model of care, which was what ranked us so high on the grant response. And so, we're going to try to take some of those encounter rate and fee-for-service funds, but we have to find alternative sources of funding. And integrated care aligns really nicely with a lot of the grants that are available out there. It aligns really nicely with what a lot of the ACHs have been doing. And so we're going to continue pursuing those efforts. And then commercial payer contracts have been very difficult for rural health systems to get into a shared savings agreement. We don't have a lot of bodies, so the negotiation really isn't a negotiation at all. And in fact, it's hard to get them to the table. But we keep sort of pestering them, and I think one of the keys to this is the data and the metrics. I think that's one thing we don't want to overlook in all of this with behavioral health, is you got to start tracking what you're doing. You have to track your impact on the population, and then you have to start looking at your payer and say, wow, I've got quite a bit of Molina patients in this program. I'm going to take that data and I'm going to show Molina that we've intervened and we've created these savings, and we'd like to keep the program going for them to keep those savings down. But I have to sell it on them. I mean, they're not coming knocking on my door saying, hey, we want to have a shared savings agreement with you. I'm going to have to actually go out and kind of pester them and provide them the data about how we're caring for their population. A lot of the EHRs don't do this well. I mean, ours really does not do this well. And so we ended up buying a third-party application, population health application called Enly. And Enly allows us to roster patients into panels, and then we can track a bunch of metrics within that application. And so if you're going to embark on integrated models of care, I would start like immediately with what are you trying to fix and how are you going to measure that you are actually fixing it. PHQ-9s are actually a terrible way to look at your program and say, am I making an impact? Because you do a PHQ-9 once in 12 months. If they're in active treatment, you will still survey PHQ-9 more frequently. But to think that you're going to go 12 months with a 50% reduction in your PHQ-9 when you have a really sick population, you're not. You're doing great work, and the patients can tell you that you're doing great work. Yeah, no, I don't want to stop coming. But what you're going to get in those measurements is you're going to get these periodic bumps in the PHQ-9, which is going to look like the program's not really helping them. So you have to find other ways to measure the success. And some of it is, through these population health initiatives, tracking their ER usage, tracking their inpatient usage, SUD, substance use disorder, are they self-medicating? You have to really tease out whether or not the program's effective. A lot of this is just really challenging work to get paid for. Like, what's the CPT code for getting an agoraphobic person out of their house into an appointment? I mean, I have an MSW who's acting as a community health worker. Most people don't have 6-year master's level folks doing that. But it's because this population is so challenging to manage in their day-to-day lives that I have a guy who I can't even bill for services who really is a behavioral health worker. He's not licensed, so I can't charge for him. But he's out there making sure these folks get to their appointments. And he's out there, his name's Paul Isle, by the way. I call it guerrilla healthcare. It's like, guerrilla warfare. But we're engaging these folks most of the time outside of the 4 walls of the organization. And so, is the work worth it? Absolutely. Is it going to make your population more healthy? Absolutely. Are you going to be able to get it paid for? No. I mean, it will hopefully break even at its best. You're going to have to really look for creative ways to fund the program and develop the program. So I know that I was last on the list, and I know that happy hour is coming. And so, I kind of pushed through this because I wanted to leave some time for questions if you had any. And if you didn't have any questions, well, then it's happy hour time, and I still win, right?
So you mentioned that, am I on?
No, but I can hear you.
Yeah. I'm usually loud enough to fill the room, but if we're trying to get online, I can't yell loud enough to hit the internet. So is there a way to gather up this kind of information and maybe affect policy over time? I mean, I've got to believe that lots of people care about that systemic cost of those frequent flyers. It's got to be something that you can do something about if you get enough data behind it. Right?
Groundswell, right? We need not only data, but we need the groundswell of folks that are doing this good work universally. And I think one of the challenges is we don't, as hospitals, we don't always get together to try to make an impact and measure the same thing. So a lot of times what I find when I talk to my peers is we're measuring X and they're measuring Y. And so it's hard to get that groundswell of data that we were talking about. Although, within the last couple of years within Washington State, especially with the ACHs, they sort of were the ones that kicked off the PHQ-9 and GAD-7 thing. Because they were at least going to say these 2 measurement tools can tell you a lot about what's going on in these populations.
FQHCs do a lot of community outreach and stuff too. So I mean, there's probably ways to reach across some of those different organizations to
FQHC's pioneered integrated care, really, in a lot of ways.
So,
yeah, I agree. I mean, I just had a legislative experience, right, where I got told to talk to a legislator, and I had 2 minutes. And so, but I had to sit through these other things, and then when it came our time to talk, they said, guess what? You have 1 minute now because we ran out of time. Right. And so how do you talk about the complexities of behavioral health and the behavioral health situation that you have in your community in 1 minute in any kind of way? And so it's going to take a lot.
Talk really fast.
Yes.
Of your senior population, how many are on traditional Medicare, Medicare with a sup, or Medicare Advantage? Because I think that affects how they get their services.
You're going to love this one. Medicare Advantage won't credential with me. They advertise in my community, but all the Medicare Advantage contracts are in Walla Walla. And so when the people call and they say, no, it's still Medicare, you still get your care, you still get your service, they switch over and then they find out that we're not credentialed with them. And they won't answer our calls when we tell them this. So our public hospital district is in Columbia County and Waitsburg, Washington is in Walla Walla County, but it's a part of our public hospital district. And I bet you 30% of my Medicare population is switched to Advantage plans in Waitsburg, and I can't get paid.
Okay.
Thank you for your talk. This is an excellent topic, and I don't think it's addressed enough. But are you familiar with health coaches that some insurance companies provide? And do you see them playing a role in this? You know, they kind of address compliance to what the orders are from the doctor as opposed to being actual behavioral health professionals. But they can help maybe bridge a gap. They can maybe help identify more high-risk people, or they can help provide some basic motivational interviewing to get patients to be more compliant, right? Because at the end of the day, there's something else affecting their ability to be compliant with what will help get them better from a physical standpoint. And perhaps they can bridge that gap a little bit.
Absolutely. I'm glad they stopped calling themselves care coordinators, though, because every one of us were using the term care coordinator, but it meant something different. You'd call them up and you'd say, hey, I'm your care coordinator. Yeah, I just talked to you on the phone the other day. It was the insurance company's care coordinator that was talking to them. And so one of the things that would be really nice is better collaboration between the insurance companies and us. They actually know more about those patients than we do a lot because, like, from our perspective, we do not have any specialists really in our organization. So they may go to Walla Walla for a specialist, and that specialist might prescribe medication, but we don't really have access to that necessarily if we don't get the charts and information back. But the insurance company has all that information, right? And so it really would be great for them to help us risk stratify their people within our community so that we could get and glean that information and partner with them. And that way, if their coach engages and starts noticing something different in behavior or in the tone, I mean, how nice would it be for them to give us a call and give us a heads up, because we got a care team wrapped around that individual as well, and we can proactively address it.
Yeah, absolutely. And I think that it's so important to have this integration because, and I'll just share a brief example, doctors aren't necessarily taught to do this, right? They are taught to be the smartest person in the room, but they're not necessarily taught to listen as much as maybe we would want them to. And so an example that was given to me by a health coach was a patient that she was working with. She had high blood sugar. So she went to the doctor, and the doctors said, okay, don't drink any soda, take this medication, and walk 3 times a week. Okay. A month goes by, and the patient comes back in, and she has high blood sugar still. So the doctor says, did you stop drinking soda? She goes, yeah. He's like, did you take the medication? She says, yeah. Are you walking 3 times a week? Yeah. So what's the doctor going to do? He's going to change the medication, right? Or he's going to double it up. The question that should have been asked and that the health coach did ask was, you stopped drinking soda, what are you drinking now? Oh, I drink orange juice. Because it's a fruit and it's healthy for you, right? So it's a simple change in the approach that can change the outcome of that particular patient's health. And if they can get off of soda and off of sugary drinks and walk 3 times a day, they probably won't need that medication, right?
Yeah, no, it's a fantastic example. We had a gentleman who was suffering from alcohol use disorder. I mean, it was terrible. In the ER every week. Doctors trying to do stuff, EMS, a lot of resources in the community being spent. Paul Isle, my social worker, started just hanging out at his house, checking on him. How are you doing? They started listening to records, vinyl records. 3 record listening sessions later, we were able to get him to an inpatient program at the VA because we had built a relationship with him. We were in his house. We were there with him. And he was opening up in a way that he wasn't doing in these little brief interactions that he was having. And so sometimes healthcare is exactly what you said. It's just listening. And there's not a lot of room in the system for that because there's no reimbursement for it, right? And so, again, these are worthy causes, and it's worthwhile to get in there and dig and try to find ways to fund these programs. And then, think about measuring the outcomes immediately from day one. How do I measure an outcome for listening to vinyl records? Right? The outcome was we got him into an inpatient program and he stopped swinging in and out of the ER, but we had to sort of find a way to panel this gentleman in a way that would allow us to sort of track what was going on specifically for him. So it's worth the effort for sure. Thank you for bringing that up.
So during COVID, I'm curious with all the lack of reimbursement coming to behavioral health, which clearly needs to be increased, have you started to see big changes in discussion across legislative communities to really start to support this more? Is it still a huge push needed from our reimbursements and our patients to push that further? I mean, you've addressed some of it here, but I'm just curious if this is going to really help as we're looking at such a huge mental health crisis across our nation.
Yeah, and we see this in two regards. One is we're not making enough of the people that we need to do the work.
Yeah.
I mean, even from just like basic healthcare perspective, there's 6,000 nurse positions open in Washington State that can't be filled right now. I mean, we're not even really getting it right at the basic level, which is nurses taking care of patients at bedside, let alone thinking about cranking out LICSWs. And Washington State has one of the highest hour commitments. 4,000 hours is incredible. I mean, a lot of the states have lower requirements for that, and so we're just not making enough of the providers, for one. We're still in fee-for-service land and encounter rate land, which means 30-minute, 45-minute, 60-minute visits, and a lot of this doesn't fit within that. And so it'd be really nice if we can get some way to get out of that fee-for-service mentality here in a meaningful way. And then the other side of it is legislators think that telehealth is going to fix everything. Like just computer, you'll have a camera, you'll be able to meet with a psychiatrist in Florida. He lives in Florida, but he's providing service in Washington because you subscribe for it. And rural in particular, we don't broadband to people's homes. Yeah. Like it's not practical in most cases. In an aged population, technology is a hurdle anyway. And so they've increased the rate for those telehealth encounters, and I don't want to be too cynical about them. I mean, we're trying to use them ourselves, but what we're not getting is that meaningful interaction at the right time. Sometimes it really is catching an individual at the right moment, and that's boots on the ground and people, in homes and working with folks. I mean, if we still want to build these programs around, oh sure, just schedule an appointment, it doesn't always get it done. I'm just so happy to see people.
So, with the accomplishments in there for the last couple of years, where are your sights for the next 2 or 3 years in this arena?
Yeah, we're spending a lot of time and resources on transportation. We're spending a lot of resources on non-clinical folks that can help get people and engage people in the home. And we are spending some resources to try to get more LICSWs into the program. We've even contemplated a licensed psychologist as well, because counseling is a huge part of this. Substance use disorder is not something that we've been doing really well right now. And it's really weird, like Tasha I was telling you about, she actually was doing SUD and she could do an SDUD assessment, but none of the places that did inpatient treatments would accept her assessments. They'd have to repeat them. And so, I mean, there's just some weird quirk things in the system that are actually hurdles for folks, and it's hurdles for getting folks into programs. And then those programs are almost never in their community. Like, from our perspective, we're always trying to find a bed somewhere else. We're in Columbia County, Sundown is in Yakima County, and so, hey, we got a bed in Sundown, but that really means 2.5 hours away from their support system. And so, I mean, there's just some things like that we're trying to figure out on how to build upon what we've done. But can we get resources closer to our community in order to support these folks with some of the things that we can do?
Thank you so much for doing this very important work. I was wondering about community, like group therapy or other resources that you could maybe integrate with. Are you doing a lot of that, or is that helping alleviate some of the demand? Are you able to integrate support groups, I guess, is what I'm thinking, in addition to the individual therapy?
In the context of what's probably still a fairly immature program, right? Because we've only been doing it in earnest for 3 years, even though we started really thinking about what mental health looked like in our community 5 years ago. People don't even feel comfortable coming and talking to their doctor behind a door, and it's just them and their provider. And we're trying to build these trust elements to get them to even start talking and acknowledging about these things. Men are the worst. They'll seek care last on everything, and mental health, somewhere along the line, it was a father like mine that said, mental health, rub some dirt in it. you know? And we are really having a challenge with that. Like, we can get them to fill out the form, and they'll be clinically depressed, and then we try to say, you know, we'd like to get you some help, we'd like to connect you with somebody. They don't come, they don't go. No, I'll be fine. I just need to work it out. I just need to get through it. And so, you know, we've talked about maybe we can get some of these programs together or partner with some of the churches in the area. So we, like our palliative care program, all of the pastors in the community are part of our palliative care program. If you're part of that, we will say, would you like to meet with somebody? And the pastors will actually meet with those individuals. And we thought, well, maybe that would be a good segue into some of the behavioral health challenges we have, because they definitely have relationships within their church community. The schools have been just incredibly difficult for us. We started parking behavioral health providers twice a week in there. And you know, the kids, oh, you went behind that door. That's the behavioral health provider, you know? I mean, there's still a stigma that's really hard to get past. And, you know, some of the communities may be more mature in their programs, and they may be able to get some of these community-type groups together. But for us, when we've tried, nobody shows up. Like, Facebook, right? 80 thumbs up. This is awesome. And then the night of the event, like, nobody shows up. It's just really weird. And I don't know if it's a small town thing. I can only talk from my perspective of rural Washington, but it's very challenging for us right now.
Well, thank you.
Yeah.
Thank you. So we have a couple of questions in the chat. So the first is, as some issues such as childhood trauma and resulting CPTSD don't always respond to traditional therapy, have you been successful with recruiting therapists who are either trained in more specialized techniques, in parentheses, EMDR, CBT, CPT, DBT, or are you providing incentives for therapists to get trained in these techniques? And then he or she has a clarification, CPTSD equals chronic PTSD.
Right. We actually have used EMDR quite a bit. Both of our providers were EMDR trained, and we use that tool quite extensively with some of our most chronically ill. And it was interesting. It's like, you really, from the perspective of what that does, it's like you don't do that at school in a quick session and then send them back to class. Most people that go through those, like, that's all they can do. Like, it starts really making inroads into some of that trauma. And a lot of times we see people just exhausted from a 45-minute visit. And for us, what we also know is that we're going to wrap other services around them when we're in that process.
Great. And then one more question. This is from Harold in the chat. He has a question. Having grown up in the sticks with the amount of agriculture production and the impact on the food supply, have you reached out for grant funding from some of the wholesale buyers of your wheat? Not to mention the need to have medical services for farm machinery injuries.
Yeah. A lot of people don't know, if you go out and look at some of the studies at depression and anxiety in farmers, it's a really high number. I mean, every year you're starting with a bank loan. You've got thousands of acres. You're reliant on the weather. There's a lot of stress. There's a high rate of suicide in farmers. And so we absolutely have engaged the industry, but it's a jump for them to think about, you know, I sell spray and fertilizer, I'm going to fund behavioral health or mental health. You know, I mean, so we're really trying to get people to understand that this is sort of like it takes a village, right? We're partnering. I mean, one of the examples is we have a memory care program. We call it Memory Cafe. People that have been early onset Alzheimer's or dementia, and even some people that are further into it. We've partnered with some of the businesses in the community. We've trained them. They have a Memory Cafe day, and it's the business is generally only open for those folks, so that if there are outbursts or something like that, it's okay. It's not going to disrupt the business. But the point is that people end up isolating when they get those diagnoses. The caregiver doesn't leave the house and feels like they can't get out, and the person affected with it becomes more and more isolated, which actually makes things worse. And so the other thing we did is memory care training for like all the businesses that wanted it. So a bank teller, for example, has been dealing with Mr. Jones for years, all of a sudden starts noticing that, wow, his account's going, he's like bouncing checks. He never does that. Now they're trained to say, oh, I've recognized some memory issues with him. And they're an early warning sign for family members to say, hey, look, we've noticed these things, we've had this training. And so now the whole community is sort of like Alzheimer's and dementia trained from that perspective, and we're all using these, we call them the gem states, like, oh, he's in the pearl phase or in the diamond phase, So it sort of breaks these things down to the different phases of the disease. But that's one way we've engaged the community and sort of given the work back to them from a healthcare perspective. And again, those trusted relationships have existed for a long time. And so oftentimes an encouragement from somebody to get some help goes a long way.
Okay, so it looks like there's one more from Elisa through the chat. As a person who grew up in a frontier area, the issue is a lack of anonymity when you're in such a small population. So maybe it's more of a comment. It's a small town thing, Harold says. So
that's why integrated care is so awesome. You're not getting a prescription to go to where the psychiatrists work in the building that everybody knows the psychiatrists are in, or everybody knows. They're just coming to the clinic. They get checked in at the front desk like any other patient. They sit down and wait. They get called back by a nurse like any other patient. So there's no way to distinguish whether or not they're getting behavioral health treatment or clinical treatment. And I think that's one of the key aspects of an integrated model of care is it sort of removes that. They're just one car in the parking lot along with a bunch of other cars at the clinic.
all right, that looks like it's it in the chat. Are there other questions in the room? Any last questions? Oh, over here.
So you were talking about your work with Medicare, like Molina providers. What are you doing with commercial payers, and how receptive are they to that integrated care model? And then second question is, tagging along to Teresa, the younger population, we're thinking we're coming out of this pandemic, how that affected young population. How are you preparing for this patient wave, let's say, in 5 years?
Yeah, so a couple of challenges. I'm going to talk about the kids first. Not every behavioral health provider you hire is going to be comfortable working with children. And in Wayne and Tasha's perspective, they wouldn't take anybody under 14 years of age. They just weren't comfortable with age groups that low. And that wasn't anything we really were thinking about when we initially hired. That's sort of a question you have to tease out of your candidate. Are you comfortable seeing children? And if you are, to what age are you comfortable working with them? We wanted to get into the schools because of that. We knew that it was not even an encounter rate, it was nothing. We were putting the resource there, we were given hours, we were telling people they were available, and kids would just come in. And the theory was that if a conversation worked and they went back to school and they felt better, great, but if there was deeper issues, then what we do is refer them to the clinic so that they could actually see regular treatment, that type of thing. We're worried about our children. We're worried about the effects of the last couple of years, and some of the studies that we've seen. They just recently did a study with the 10th grade group at Dayton. It's like over 50% of that population has thought about suicide. That's a lot. That's a big number, So we're working hard to make interventions there. Commercial payers, from a rural perspective, the contract that they present you is the contract you get. We don't really get to negotiate very well. And so what we're trying to do is start working with associations of other hospitals and individuals that are negotiating contracts with the commercial payers will not just negotiate for Dayton, but they'll wait and they'll bundle 7 hospitals together to try to get better negotiation. Commercial payers are very clear on what they'll pay. We do, like all of the codes that I showed you, they'll pay on those. And they'll just pay whatever contracted rate it is. Most of the time it's actually under what it actually costs to deliver the care, though. Thank you for all the questions. It made it so much better than a PowerPoint.
Last call for questions? No? All right, well, thank you, Shane. Awesome. Give him a round of applause.